Hey Detroit, how are you? How was your break? Good? All right, are we ready to start moving? All right. I'm gonna ask you to stand up, and we're gonna pretend we're walking on sunshine. Guys, got your heart rates up? Perfect. That's what I like to hear. Let me catch my breath. Hold on. All right. Who knows what power is? Who's taken a power class before? So it's Parkinson's Wellness Recovery Project. And what those moves do is gives us back the big that Parkinson's takes away from us. Okay? They're big movements that we bring into our life to gain back and keep our independence. Today, we are going to show you that you can do hard things. All right? So let's follow along. Everyone, make yourself a star. Nice and big, watch your partner.
I got this feeling inside my bones. It goes electric wavy when I turn it on. All through my city, all through my home. We're flying up, no ceiling when we in our zone. I got that sunshine in my pocket, got that good soul in my feet. I feel that hot blood in my body when it drops. Ooh, I can't take my eyes off of it, moving so phenomenally. You're more like the way we rock it, so don't stop. And under the lights, when
You just did hard things. So don't let anyone tell you can't, okay? That's the deal today. So, third song, third and final, but it might be the most important, okay? Who knows what month it is? Which is?
Parkinson Month.
That it is. So, in celebration of Parkinson's Awareness Month, Michigan Parkinson's Foundation will be having a sit-to-stand challenge to raise awareness for Parkinson's disease. Today, there are over 600 people in attendance, and I invite you, every single one of you, to help me take a stand against Parkinson's by doing some sit-to-stands. How do we feel about that? All right, we all have a chair, right? I want you to take a second and get it where you are comfortable. Thank you. Oh, it's nice to sit. All right, so when we are sitting in our chair, a couple things I want you to check. I don't say this often, but look at your feet. Are your legs separated? Okay. You have a nice wide base. And your entire foot is imprinted into the floor. Check, check? Cool. All right. Our backs are away from the back of the chair. Now, when we do sit-to-stands or power-ups, when we're sitting in a chair, we need that little momentum to get up. Think about your big comfy chair at home and trying to get out of it, okay? You got to swing and up and down. So we want to break this down a little bit. What I want you to do, and I'm turning this off, so listen closely. All right, so when we're coming out of our chair, we are going to shoot forward. We're shifting our weight forward. As we stand up, making everything big, okay? When we come back down, sit down, and we're right back to it. And down. Oh, we all just did 2. Woo! There's 1,200, guys. How many can we do in 45 seconds of a song? All right. We're going to do it together, 45 seconds, because we're titanium. Ready? All right, DJ. You need music. All right, let's get ready. 1, go. 2, make it big. 3, go.
You shut it out, but I can't hear a word you say. I'm talking loud, not saying much. I'm criticized, but how you are, but it's ricochet. Shoot me down, but I get up. I'm bulletproof, nothing to lose. Far away, ricochet. You take your aim. Far away. You shoot me down, but I'm a bomb. I am titanium. You shoot me down, but I'm a bomb. I am
So you just did a lot of hard things. What is it? 12,400. Way to be quick. That's amazing, guys. Keep up the good work. And here's a challenge to you. Take a little video of you, your family members, your neighbors, your grandkids, whomever, doing some sit to stands. Count them up and tag Michigan Parkinson's Foundation online, okay? We're in this together, all right? Enjoy the rest of the day.
$12,400. We're looking really good. Okay, thank you, Ashleigh. Thanks, everybody. Just so you know, we did ask them to turn the air up. It's coming. In about an hour, everybody will ask me to turn it down. We'll do our best. Okay, I am excited to announce our next speaker. I'd like you to join me in welcoming Dr. Danika Paulo, a functional neurosurgeon at Henry Ford Health. She specializes in the surgical treatment of movement disorders, including Parkinson's disease, with a focus on improving quality of life through advanced patient-centered care. Her expertise in functional neurosurgery and dedication to innovation make her a valued leader in this field. We are honored to have her today and share her knowledge and insights. Dr. Paulo?
All right. Thank you, Julia, for that wonderful introduction. Good morning, everyone. It's a pleasure to be here with you, and what great turnout for such an awesome event. So thank you for all being here. I'm honored to be a speaker. Thank you to the Michigan Parkinson's Foundation for inviting me. So today, what I'm going to talk to you about are advanced treatment options for Parkinson's disease. So as a functional neurosurgeon, I specialize in procedures that help patients with Parkinson's disease that are really impacted by the movement disorder, the motor symptoms. And we're fortunate now to have multiple treatment options beyond medication that can help with this disease and getting back that quality of life so you can enjoy it to the most. So over the next hour, my goal is to help you understand what these treatments are, how they work, who they are best suited for, and most importantly, when to start thinking about them. I want to emphasize right from the beginning that these are not last resort treatments. In fact, the timing of referral is one of the most important factors in achieving good outcomes. So the window of opportunity really is before severe balance problems or cognitive decline develop. And before we dive in, I'd like to get a sense in the room. How many of you have heard of deep brain stimulation before? All right, great. It's a therapy that's been around for about 3 decades now, so not surprising. What about focused ultrasound? How many of you have heard of focused ultrasound? All right, a little bit more sparse. I'm going to get into both of these in my talk. So I want to take a moment to understand your experiences because Parkinson's disease can look very different from person to person. So quick poll, raise your hand. If you or your loved one are living with Parkinson's disease, how long have they had it? Less than 2 years? Newly diagnosed? All right, great. 2 to 5 years? Okay. What about 5 to 10 years? Good amount. And then more than 10 years? Wow. All right, thank you for sharing. And what symptom or issue is most affecting daily life? There's a whole constellation of symptoms, some more prevalent in certain patients. So is it really the tremor or the shaking? How much is that bothersome? All right, great. Motor fluctuations is another common symptom. What about the motor fluctuations with medications? Yep. All right. And then the dyskinesias, the involuntary movements after you take the medications. All right. And then balance issues or falls related to that. Yeah, so fortunately, these interventions can help treat a lot of those motor symptoms. Thank you for sharing. So to understand where we are today, it helps to understand the history of DBS. Long before DBS existed as a treatment option, neurosurgeons treated Parkinson's disease by lesioning, or creating a targeted destruction of brain tissue. It was small and could lead to immediate improvement of symptoms. This is how we really got to understand the anatomy underlying the movement disorders and what could lead to improvement. They were particularly effective for tremor, but the downside of these treatments were that they were permanent and not adjustable in the long term. So performing them on both sides of the brain also carried significant risks, particularly with speech and cognition. And then in the late 1980s, a French neurosurgeon named Alim Louis Benabide made a critical observation while he was performing one of these lesioning procedures. He noticed that low-frequency stimulation of the brain tissue actually worsened tremor, but that high-frequency stimulation at around 100 hertz suppressed it. So this led to a major insight that high-frequency stimulation could essentially mimic the effect of a lesion. But the advantage was that it was reversible, adjustable, and potentially safer, especially when treating both sides of the brain. So that observation is what launched the modern era of deep brain stimulation. Following that discovery, deep brain stimulation was initially used to treat tremor, particularly in the thalamus, for essential tremor. As our understanding of the brain's movement circuits improved, we began targeting other areas of the brain, namely the subthalamic nucleus and the globus pallidus internus, which are now the two main targets used to treat Parkinson's disease with DBS. And they allow us not just to treat tremor, but also to treat stiffness, slowness, and the motor fluctuations that we just talked about, really addressing the broader motor symptoms of Parkinson's disease. And then over time, bilateral deep brain stimulation became standard, and it evolved into a comprehensive therapy for Parkinson's disease rather than just a tremor treatment. So we can talk a little bit about the evidence and the main studies. This is one of the most important aspects of the history of DBS. So large clinical trials have shown that deep brain stimulation, when combined with medication, is more effective than medication alone. Patients gained, on average, about 4.5 additional hours per day of on time when you're feeling good, symptoms are well controlled without the troublesome side effects. About 70% of patients experienced meaningful improvement in tremor function, and many were able to reduce their medications significantly. Overall, patient satisfaction with the DBS procedure is very high, around 85%. But I want to make this real and tangible and relevant, not just telling you numbers. So I often ask patients, what would you do in your day with an extra 4 or 5 good hours? Would it mean being able to go out more, spend more time with family and friends, or simply just feel more like yourself? Because that's really what these numbers represent. Several landmark studies between the years of 2009 and 2014 really helped define the role of DBS. In 2009, there was a large study published in the Journal of American Medicine that showed that patients receiving bilateral deep brain stimulation had significantly better outcomes than those on best medical therapy alone. This is the study that showed an increase of 4.5 good hours of movement per day. This was followed by a 2010 trial that compared the targets, the STN and the GPI, and showed that they provided similar motor benefits, but with different trade-offs and slightly different advantages. For example, the subthalamic nucleus target allowed for greater medication reduction, while the globus pallidus internus had some advantages in terms of mood outcomes. Subsequent studies then explored the efficacy of earlier intervention, so doing deep brain stimulation earlier in the disease process, and confirmed that benefits are durable over several years, and it may help slow the progression of the disease. And then later studies also showed sustained improvements in quality of life. There was a lot more focus because that's what is most relevant to you, the quality of life improvement. So it really is making strides in that regard. The key takeaway is that DBS is not only effective, but its benefits are long-lasting and well supported by high-quality evidence, especially because it's been around for decades. So who benefits the most? Finding the right fit. This is one of the most important slides on my talk. We often talk about a Goldilocks window for advanced therapies, meaning it's not too early in the disease process, that it's not worth the risks of doing this procedure, and it's not too late that it would make it too high risk to proceed with. So the best candidates are really those who still respond to medication, but are experiencing motor fluctuations, significant off time, or medication side effects. We want to intervene before severe balance problems or cognitive decline develop, because these symptoms are less responsive to these treatments and often make them higher risk. One of the biggest challenges we see is that when patients are referred too late, that window has started to close. So it's really an important discussion to have with your neurologist if you're even considering one of these therapies, because they can help refer you to a specialized movement disorder center that can help lead these nuanced discussions and decision making. So the primary inclusion criteria for DBS is if you carried a diagnosis of Parkinson's disease, your medication, your carbidopa, levodopa, still works for you, and your symptoms improve when you take your medication. That suggests that you would have a good response to DBS. What DBS should feel like is what you feel like when you're on and in a good state of your medication. If you have more than 2 hours a day when your symptoms return, despite taking your medication as prescribed, it's good to consider DBS. And tremor, rigidity, dyskinesias that persist with medications. It's important going into this to have realistic expectations about the treatment. It's not going to cure Parkinson's. It's not going to take away all of your symptoms, but it can significantly reduce the impact and improve your quality of life. Again, timing is key. So after the medication benefit starts to fade, but before severe balance or memory problems. And then that you're healthy enough to undergo surgery from a medical standpoint. While DBS can be incredibly effective, it is not the right option for everyone at every stage. There are certain factors that make us pause and think more carefully. For example, if someone has significant memory problems or difficulty with daily tasks, DBS may not be the best option because cognition can impact both safety and outcomes. Similarly, if there are psychiatric comorbidities like depression or anxiety that are severe and untreated, those should be addressed first, as mental health plays a major role in recovery and patient satisfaction. We also think carefully about patients whose symptoms don't respond well to Parkinson's medications. This may suggest a different diagnosis where DBS is less effective, but focused ultrasound is still a good option for those patients. And from a medical standpoint, serious health conditions, advanced balance, or speech issues may limit benefit or increase risk. There are no absolute rules of who is or who isn't a candidate, and many of these factors can change over time, so patients can be reevaluated. The key point is that it is a thoughtful, individualized, mutual decision-making process. My role as a neurosurgeon is to inform you of the benefits and risks of these therapies and help guide you to the right decision that's best for you, which I listen to a lot of your input and what goals you want out of the therapy. You are the star of the show. Okay. So I want to talk you through what the DBS journey actually looks like. Understanding this process hopefully will help reduce a lot of the anxiety around brain surgery. So it starts with a very thorough preoperative workup that includes a CAT scan, an MRI, motor testing, where you come in off of your medications, you go through the UPDRS symptom assessment, then you take your medications and repeat the same assessment so we can see how much you respond to the dopamine. It also includes a very thorough neuropsychiatric evaluation. That way we understand your baseline cognition and your mood, and we can appropriately counsel you on the risks potentially associated with surgery. So all of that can take a couple months. Once we have all of that data, we have a movement disorder conference where neurologists, neurosurgeons, neuropsychiatrists all meet and discuss the data that's been collected so far and make a mutual agreement about what we feel is best to achieve your goals of therapy. And then we share that with you. If that aligns with deep brain stimulation, then we proceed with the surgical part. I do take extreme precaution on the preoperative planning to target an area that will get you the best benefit and avoid areas that may cause you side effects. So I do the plan even before we get into the operating room. And then I do the surgery in 2 stages. The first stage of which is electrode implantation, and I included some high-tech equipment that I use in the OR, the middle 2 pictures, one of which is a robot, the other is a skull-mounted device. Both of these devices are used to keep me very accurate and precise on the plan that I make before surgery. So the first stage is getting the electrodes to the right spot. We can do this awake or asleep. Traditionally, it was done awake, where you were awake for part of the surgery. We turn on the stimulation, see the benefit that you get as well as any side effects. More recently, now that we have advanced neuroimaging and these really high-tech devices that keep us super accurate, we are now, as a country, moving more towards doing it asleep with image guidance. So that is an option, and that's something that I talk about with each patient in the initial consultation. So once the electrodes are in place, that is a one-night stay in the hospital. Most patients go home the next day. Then a week or 2 later, you come back for the second stage, which is electrode extension wire implantation and the battery. The battery sits in the chest, much like a pacemaker, and it powers the device. That is an outpatient procedure. Everybody does it under general anesthesia, and you go home the same day. At that point, the system is in, but it is not on. It doesn't get turned on until 2 to 4 weeks later when you see your programming neurologist. And they will do a very thorough evaluation and try many different settings. But it does take several programming visits to get you to an optimal level. So it's not immediate. Some effects are immediate, but really to get the full benefit, it takes several programming sessions. And then you follow up with your movement disorder neurologist every few months to annually, and they'll adjust the settings as needed based on how you're doing. So let's go into a bit more of the detail about the procedure itself. As I mentioned before surgery, we perform detailed brain imaging to map out the safest and most effective pathway to get the electrode from the surface of the brain down to the target. We select either the STN or the GPI, which are the 2 brain regions that are FDA approved for Parkinson's disease, and we know that they have good efficacy. So we listen to what your main symptoms are, what your goals of the therapy are, and pick one of these 2 targets. During the procedure, we place the electrodes with high precision, sometimes doing intraoperative testing to confirm that the electrode is in the right location. Patients can sometimes be concerned about whether they will be awake or asleep, and that's a mutual decision that we would make together. Even when patients are awake, they are still comfortable and well supported by our team and the anesthesia team. And then a week or 2 later, after the electrodes are placed, we implant the extension wires and the battery, and patients go home the same day. People generally recover very quickly, and the improvement, as I mentioned, is not immediate. It builds over time as we adjust the stimulation settings. So what can you realistically expect out of this therapy? Most patients experience more good hours per day, often 4 to 5 additional hours where symptoms are well controlled. There is significant improvement in tremor, stiffness, slowness, and most patients have less dyskinesia and are able to reduce their medications. Overall, the quality of life improves and patient satisfaction is very high. That said, it's still important to be honest about the risks. It is a surgery after all. There is a small risk of bleeding in the brain, about 2 to 3%. If it does occur, it's often something we see on a CAT scan, not something that causes you any clinical symptoms. If it does cause you clinical symptoms, which is way less than 2 to 3%, it's very often transient and nothing permanent. The other complication of surgery that we preoccupy ourselves with a lot is infection. This can occur in about 5% of cases, and it can be difficult to clear because it's a non-living tissue. So even if antibiotics are circulating through your system, it's not going to penetrate the device, so the infection may spread, and ultimately it may need to come out. That's even way less than 5%, but it is still possible. We do give you IV antibiotics before surgery and redose it throughout to prevent that, and then put powdered antibiotics directly into the wounds. So there are ways that we can minimize both of these risks, but it's still possible. Some patients may experience changes in speech, mood, or balance. If this does happen, it's often related to the stimulation itself as opposed to something related to surgery. So now the programming settings can be adjusted to avoid those kinds of stimulation-related side effects. Most of these complications are manageable and many improve over time, but they are important to discuss. So one of the most exciting aspects of this field, which is one of the things that drew me to it, is how quickly it is evolving. DBS is not the same therapy it was even 5 or 10 years ago when I started learning about neurosurgery. Now we have technologies that make the treatment much more personalized, more precise, and more convenient for you all. These advances are helping us improve outcomes and reduce burden on patients. So I'll get into this in more detail. So one new advancement is what's called adaptive or closed-loop DBS. It's essentially much like a smart thermostat for the brain. So traditional deep brain stimulation delivers constant stimulation, but life is dynamic. The brain signals and your symptom severity changes based on when you took your medications, if you're awake or asleep, if you're sitting down or up and being active. So adaptive DBS can adjust the stimulation in real time based on brain signals, increasing or decreasing the stimulation as shown in the graph on the bottom right, depending on what the patient needs at that particular moment. And this happens without you even having to think about it. This means more personalized treatment, fewer clinic visits, potentially better battery life, and fewer stimulation-related side effects. There was a large study out of UCSF called the ADAPT-PD trial that came out in 2024, and it showed that patients had improved motor control compared to traditional DBS. So this is a major step towards truly responsive, individualized neuromodulation. Another advancement in DBS technology is image-guided programming. So traditionally, programming DBS relied on trial and error of programming settings and adjusting settings over multiple visits, which can be costly, time-consuming for you and the provider. Now we can use detailed brain imaging to guide us toward the optimal settings more quickly. This can improve symptom control, reduce the number of adjustment visits needed before you get to that optimal stimulation stage, and help you reach your best outcome faster. It's also particularly helpful for patients who haven't achieved optimal results with the standard programming approaches, or perhaps maybe had some benefit initially and then lost it. So this image-guided programming is another way to streamline that process. Remote programming is another major innovation that improves convenience and access to care for patients. So with this technology, we can adjust deep brain stimulation settings through secure video visits, allowing patients to receive care from the convenience of your own home. So if you are at home on Wi-Fi and your provider is in the office on Wi-Fi, with one of these systems, they can remotely adjust the settings. So it's particularly helpful for patients who live far from specialized centers or have mobility challenges. It saves time, reduces travel burden, and still allows us to provide high quality and personalized care. So let's apply this to a real-world example. This is a 58-year-old patient who has had Parkinson's disease for 9 years. His medication still works, but it's wearing off more quickly, and now he has several hours a day where the symptoms return. He also experiences dyskinesias when medication is at its peak effect. This is what we consider the sweet spot for DBS, that Goldilocks era. There's medication-responsive disease with motor fluctuations that are impacting daily life. So at this point, I'd ask you, would you want to consider DBS now, or would you want to wait? And which symptom do you think is most important to address in this patient? You don't actually have to answer it, just think about it. And the answer is different for everybody. Everybody will have different thresholds of when they feel their disease is severe enough to pursue one of these treatments. So now let's take a closer look at focused ultrasound. This is a non-surgical treatment that uses sound waves to target specific areas of the brain and create a permanent change that can alleviate symptoms like tremor, rigidity, dyskinesia, and slowness of movement. There are no incisions and no implanted devices. It is performed in an MRI scanner, so the patient cannot have MRI-incompatible devices in their body or severe claustrophobia. The procedure is done in 1 day, and patients see immediate improvement in their symptoms. There is no hospital stay. They come in and go home the same day. It is important to understand that this procedure creates a permanent lesion in the brain, a permanent change, so it cannot be adjusted after the fact, like deep brain stimulation. It's a very critical 1.5 to 2 hours that the patient is on the table. Beyond that, I, as a provider, cannot change the outcome. We can repeat the procedure if need be, but most often it is a one-time treatment. Because it's so new, the studies that we have go out to about 5 years of follow-up, but the majority of patients at that 5-year time point still have maintained significant symptom reduction. So again, similar to DBS, careful patient selection and goal setting right from the get-go are very essential. So to go into a little bit about the history of focused ultrasound, this therapy was first approved for tremor-dominant Parkinson's disease and targets in the same thalamic region used in earlier lesioning procedures before DBS. But the advantage is there's no opening of the skull, there's no surgery, so lower risk from that perspective. A major randomized trial published in 2020 showed that focused ultrasound subthalamotomy, so this is STN, same brain region with DBS, this could improve motor symptoms. However, there were some side effects, most commonly speech and gait issues in a small subset of patients. These were transient side effects, meaning they got better over weeks to months after the therapy. Over time, the indications to perform this procedure expanded to include symptoms like rigidity and dyskinesia, and real-world data help refine patient selection. The key advantage is that it is non-invasive and provides immediate results, but the trade-off is that it does create a permanent lesion. More recent trials have continued to support the effectiveness of focused ultrasound. A 2023 study showed that about 69% of patients had meaningful improvement in motor function or dyskinesias, with benefits sustained in many patients at 1 year. Importantly, the FDA has now approved bilateral treatment, meaning both sides of the brain can be effectively treated, although this must be done in stages at least 6 months apart for safety reasons. It is also covered by insurance. So this represents a major expansion of what focused ultrasound can offer, particularly for patients with more advanced disease who are otherwise not suitable surgical candidates, or for those who don't want to undergo a surgical procedure or live with a device in their body for the rest of their lives. This is just another timeline showing the FDA approvals, really starting in 2021, so it's been out for about 5 years now. And now we're getting to understand who are the best patients to select for this procedure. So we do offer this at Henry Ford. If you want to learn more about it, our table is over there. I'd be happy to talk to you more about it afterwards. Focused ultrasound is best suited for patients with specific symptom profiles, particularly tremor that doesn't respond well to medication. We also, in the surgical or procedural workup process, get a CT and an MRI, and we evaluate technical factors such as your skull density, as well as whether the patient can undergo an MRI safely. The skull density is an important factor because it suggests or kind of predicts how efficiently the energy will transmit through the skull down to the tissue. Patients need to understand that the effect is permanent and have realistic expectations about what the procedure can achieve. So again, it's not complete tremor resolution, but a significant improvement. It's also not going to cure Parkinson's disease. There will still be other symptoms, but it can help with the motor symptoms that are so troublesome. While it can be very effective, it is not as flexible as deep brain stimulation, so we have to be confident in our decision and our targeting for this procedure. Now for the timeline of the procedure. It is done using MRI guidance with the patient kept awake during the procedure, so we can assess for improvements in your symptoms as well as any side effects in real time. On the day of the procedure, we bring you into the hospital. It does involve a full head shave, but hopefully a small price to pay for the improvement of your symptoms. So we start with shaving your head. We do a scalp block to numb up your scalp. We place a frame on your head, and that will hold your head in place to the machine. We'll then bring you back to the MRI scanner, where we'll put a membrane over that frame that holds in cold water between your head and the helmet so that the energy can transduce more effectively. Once everything is set, you're on the table, you have the cold water in the helmet, we take an MRI first to see where the head is in space and align the transducers with the target that we planned. Again, well in advance of the start of the procedure. Then, once everything is aligned, we start with low-dose energy deliveries. These are about 11 to 15 seconds, and we want to see how effectively the energy is getting through the skull down to the target and that it's in the location that we'd expect. Then we progress to the medium-dose energy deliveries, where we want to see a little bit of symptom improvement, and we'll be asking about any side effects like any numbness or tingling of the face, arms, or legs that may make us want to move the target before we progress to the higher dose energy deliveries that create that permanent change. The higher dose energy deliveries are a bit more intense, and it's about 20 to 30 seconds, still short-lived, but that 1 or 2 higher dose energy deliveries are what really heats up the tissue to create that permanent change. Once that's done, we take the frame off, disconnect you from everything, get a post-treatment MRI scan so we can see the change that we made in the brain. Then you go to recovery for about an hour and then go home that same day. So on the time on the table is about an hour and a half, give or take. And then from walking into the hospital to walking out is about 4 to 5 hours. So most patients, again, go home the same day and notice immediate improvement, particularly in tremor. Focused ultrasound can provide dramatic improvements in symptoms, often immediately. There is no implanted hardware, which means no risk of infection related to a device and no need for further maintenance. No programming visits, no battery replacements. However, there are still risks, including speech changes, balance issues, and the fact that the treatment is permanent and cannot be adjusted after the initial treatment. These trade-offs are central to deciding whether this is the right option for you or not. I wanted to include a picture from a patient that underwent this procedure recently. He did have tremor. It was more essential tremor, but this is how we'll track the symptoms throughout the procedure. On the left is where he started. You can see he's well out of the lines with the severity of his tremor. And then on the right is after the procedure. So this is within an hour and a half or so. Not totally gone, but much, much improved. And he's already been delighted to share with me all the new things he's done with his steady hand. So another case. This case highlights a more complex scenario than the first one. We have a 73-year-old patient with tremor-dominant Parkinson's disease, memory concerns, and use of blood thinners. Here we have to weigh multiple factors: age, cognition, and bleeding risk. Focused ultrasound may be appealing because it avoids open surgery, but cognitive status and other risks still need to be carefully evaluated. It's a great example of how treatment decisions are individualized. I will say, too, for any patient that comes to my clinic, I discuss both of these treatment options, and we make this decision together. At the end of the day, there's no one-size-fits-all answer. Choosing between DBS and focused ultrasound depends on symptom profile, medication response, your personal goals of what you want to get out of the therapy, your risk tolerance, and access to care. So this is a shared decision-making process where we work together to find the best fit for each patient. So to summarize the comparison between these two treatments, DBS is adjustable, reversible, can treat both sides of the body. You don't need to wait any time between treating both sides. It requires surgery and ongoing device management. That includes battery replacements for when the batteries lose their juice, which can be anywhere from about 5 years for the non-rechargeable batteries and about 15 years for the rechargeable batteries. Focused ultrasound is non-invasive, provides immediate results, requires no device, but it is permanent and less flexible. So this trade-off is at the heart of the decision-making process. We guide patients through a structured process that includes confirming the diagnosis, identifying the most impactful symptoms that are limiting your quality of life, evaluating your overall medical health and cognition, discussing the multitude of treatment options, and setting realistic expectations. It's really a collaborative process that involves the patient, their family, and a multidisciplinary care team like the one we have at Henry Ford, which includes neurosurgeons like myself, neurologists, neuropsychiatrists, and therapists. So when to ask about advanced treatment? Patients should consider asking about advanced therapies when symptoms are no longer well controlled with medication, particularly if there are several hours of off time each day or significant side effects related to medications. The evaluation process typically takes 1 to 3 months, since it's very thorough, and involves multiple specialists to ensure safety and optimal outcomes. It's not a rushed decision. It is very thoughtful and intentional throughout the process. And our team is fortunate to have many different providers that all collaborate and work like a well-oiled machine to help comprehensively take care of you. So debunking a few myths versus facts. So myth number 1, these treatments are only for end-stage Parkinson's patients. Actually, the best results come when the treatments are done before severe walking or thinking problems develop. Timing matters, so earlier treatment can lead to better outcomes. Myth number 2, the sound wave treatment, focused ultrasound, has no risks because there's no surgery. It does avoid incisions and implants, but it can affect speech or walking, and the treatment cannot be reversed or adjusted because it is permanent, so no adjustments. Myth number 3, the brain pacemaker, or DBS, cures Parkinson's. It does not. It helps control symptoms so that you can function better. But Parkinson's continues to progress, so you'll still need your care team and your medications, but again, DBS can be adjusted to keep up with any progressions over time. So again, focus on symptom control, not a cure. So at Henry Ford, we have a very comprehensive care team that can help take care of you should you want to consider any of these more advanced treatment options. We have several movement disorder neurologists, functional neurosurgeons like myself, nurse practitioners and nursing support, and we also participate in research and clinical trials. So you really get the full gamut of care at a place like Henry Ford. We also work with PT, OT, and speech therapy to optimize your evaluation before the procedure and any recovery afterwards. We also offer other non-medical, non-surgical treatments such as Botox injections for tremor. These are the faces of our movement disorder team, our movement disorder neurologists, and our nurse practitioner, Carrie, also really focus on movement disorder patients, optimizing the medication regimens, helping make that determination of when it is a good time to consider these other treatment options, and also doing the programming afterwards. So they're going to be your continuity of care. And then functional neurosurgeons who specialize in surgical treatment of movement disorders, like myself, and my 2 partners, Dr. Ellen Eyre and Dr. Evstathios Kondilis. So to summarize, we now have powerful tools to improve quality of life for patients with Parkinson's disease. DBS offers adjustable long-term control of symptoms, while focused ultrasound offers a non-invasive alternative for selected patients. The most important takeaway is that these treatments work best when considered at the right time, not too early, not too late. And finally, this is a team-based collaborative decision. You are not making this choice alone. We are here to help you. So if you are even considering this, consider seeing a specialized movement disorder center where we can meet and talk about these options. So thank you so much for your attention. We're going to do questions at the end, and here's my email address if anyone wants to contact me. Thank you all.